Hello everyone, welcome to our channel. Today we are going to discuss about one of the very important genetic disorder in the chromosomal disorder. Chromosomal disorder, we have two types of disorders. One is autosomal disorder and the other is sex chromosomal disorders. In autosomal disorders, we will discuss about the Down syndrome. Down syndrome is a trisomy at the chromosome number 21. One additional 21 chromosome is there. So incidence of Down syndrome is 1 in 700 live birth. And what is the etiology behind the development of Down syndrome is there are three genetic forms of Down syndrome. Majority of Down syndromes are because of the meiotic non-disjunction. In meiotic non-disjunction, there is failure of chromatids to separate during the meiosis. 95% of the cases of Down syndrome is because of the meiotic non-disjunction. The other form is mosaic form, which is responsible for the 1% of the cases of Down syndrome. Mosaics or mosaicism meaning two different kinds of genetic information in the same kind of cell in a same individual. This is because of the mutation or chromosomal abnormalities during the embryogenesis, and this is accounting for the 1% of cases of Down syndrome. The third genetic form is Robertsonian translocation, in which in Robertsonian translocation, large arm of a chromosome along with the centromere translocate to the other chromosome, and there is a loss of the short arm and a part of the chromatid centromere. So Robertsonian translocation is responsible for the development of 3 to 4% of cases of Down syndrome. So these are the three genetic forms of Down syndrome. First is meiotic non-disjunction, second is mosaic form, and third is Robertsonian translocation. What is the pathogenesis behind the trisomy 21 or the development of clinical features? Presence of an extra 21st chromosome, there is overexpression of the genes of this chromosome of that additional chromosome, and they affect the cellular and developmental pathways, resulting into the characteristic phenotypic features and systemic malformation. So what are the clinical features are we have seen in a case of or in a patient of Down syndrome? This is a diagrammatic representation which is given in Robbins. So in physical features in Down syndrome, the patient is hypotonic with short stature, flat facial profile, upward slanting palpebral fissure, epicanthal fold and flat facial profile. We can see short neck with excess skin in the hands, broad and short hands with the simian crease, a single transverse palmar crease, single transverse palmar crease, clinodactyly incurved little fingers is there. In the feet, wide space between first and second toe, known as sandal gap. Wide space between first and second toe, sandal gap. These are the physical features seen in a patient of Down syndrome. In neurological and cognitive feature, one of the very important cause of mental retardation. Delayed developmental milestones, delayed motor development. In systemic malformation and comorbidities, there are so many congenital heart defects associated with the Down syndrome. Atrioventricular septal disorder, ventricular septal disorders. In GI abnormalities, duodenal atresia, Hirschsprung disease, and imperforate anus can be seen along with the Down syndrome. In endocrinal system, there is congenital hypothyroidism. In Down syndrome, there is increased risk of certain disorders like acute leukemia, especially ALL, acute lymphoblastic leukemia, and AML M7. Early onset of Alzheimer's disease, which is seen in 40 to 50 years of age, and there are immune deficiencies, sleep apnea, and atlantoaxial instability is also noted in the patient of Down syndrome. There are certain risk factors for the development of Down syndrome. The most important risk factor is maternal age. Incidence of Down syndrome is increased with the advanced maternal age, as the incidence of Down syndrome at the 25 year of maternal age is 1 in 1250 patient, and in the female or maternal age of 40, the incidence is 1 in every 100. And when the age of female or mother is 45 or more, incidence is as high as 1 in 25 live births. So advanced maternal age is the most important risk factor for the development of Down syndrome. How can we diagnose a Down syndrome? In diagnosis, we use a prenatal diagnosis or a postnatal diagnosis. In prenatal diagnosis, there are screening tests. They include first trimester testing, in which we use dual marker test, which include free beta HCG and PAP-A, pregnancy associated plasma protein A, and the ultrasound, in which we use neutral translucency. First trimester test we normally advise between 9 to 13 week of gestation. In second trimester screening test, we have triple and quadruple marker test. In triple marker test, we analyze some biochemical markers like alpha fetoprotein, HCG, and unconjugated estriol. In quadruple marker, additionally, we also measure the inhibin A level. So these are the screening tests. Whenever they indicate a significant risk of any trisomy or neural tube defect, we advise for the diagnostic test or confirmatory diagnostic test. They include chorionic blood sampling, amniocentesis, percutaneous umbilical blood sampling, and non-invasive prenatal testing, which is NIPT. In NIPT, we use cell-free fetal DNA from the maternal blood. All the screening tests are performed on the maternal blood, and diagnostic tests are, as the name suggests, CBS, chorionic blood sampling, in which we take sample from the chorionic villi. In amniocentesis, we use amniotic fluid, and in NIPT, this is the only confirmatory test in which we use maternal blood. In postnatal diagnosis, we use fetal blood or blood of the newborn for the karyotyping, in which we can clearly see there are 3 copies of the chromosome number 21.